You mentioned the gut-brain axis. In the book, you talk about the gut-brain axis and you talk about the relationship with the immune system. Can we talk a little bit more mechanistically around what's happening there? So if we do have a child who, let's say in your case with your babies who had a course of antibiotics in the first 5 weeks, or, you talk about the first 1,000 weeks in the book, 2.5 years, 3 years, let's say. What are some of the things that are happening in the gut with exposure to the antibiotics? Like what's happening and what's causing the distress in the gut that now is sending out distorted messages to the immune system and the brain?
Yeah. So one thing we know when babies are born, it's a little controversial whether or not they have a completely clean slate because there may be some passage of, microbiome materials, in organisms, even through the placenta, possibly through the cord blood. But we do know that when babies are born, the mode of delivery makes a huge impact on what microorganisms will choose to call your baby's gut their home. So a vaginally birthed baby is going to have many more probiotic species in their gut that are, quote, beneficial, including the lactobacillus species that naturally inhabit, hopefully, a woman's vaginal canal, a lot of gut microbes. In a baby who's born by cesarean section, we see a higher incidence of more pathogenic bacteria that shouldn't be in your child's gut microbiome, like skin flora, staph and strep species. And when that happens, the information that those gut microbes are sending to your child's developing brain or to your child's developing immune system, as you said, starts to become distorted. We know that, many listeners know that the vast majority of many of our, quote, brain chemicals or neurotransmitters are made by our gut microbes, so maybe up to 80% of all serotonin. But 50% of our dopamine is made by our gut microbiome. I believe that number is similar for the GABA and the acetylcholine that we use. And our gut microbiome makes over 400 times the melatonin than our brain. And so this communication, now it's not as simple, just they make these what are really called postbiotics, these byproducts that then they just go to the brain and do their thing. They have to communicate via the vagus nerve. But when we don't have the appropriate microbes to make our neurotransmitters, then you can see why it would be so challenging for a child's brain then to develop the appropriate pathways that then lead to appropriate sleep patterns, optimal stress management, and HPA responses. Same thing with the immune system. At least 70 to 80% of our immune system is housed in our gut, and our microbiome has a direct line of communication. So I have parents and kids think about, all kids have tonsils that are visible, some bigger than others, but our gut lining has tons of tonsil-like patches that are our immune system in our gut-associated lymphoid tissue. Now, that, when our microbiome communicates with our gut, then that informs our blood's immune system. How are you going to respond to whatever you're exposed to? Whether it's a food, whether it's a pathogen, whether it's an environmental toxin, are you going to mop it up and clear it away and stay calm? Are you going to have a huge immune response and create a lot of inflammation? Or maybe you're going to create the wrong immune response and have chronic persistent inflammation or an autoimmune reaction. And we start seeing this tipping over of chronic inflammation and autoimmunity at very, very young ages. In fact, one of the factors that seems to be correlated with this increased rise of an abnormal immune response, like this atopy, eczema, asthma, food allergies, is the loss of species of bacteria called bifidobacteria. And bifidobacteria for babies should be the predominant bacteria in their microbiome. When we look back over the centuries, our babies and us as adults, we were losing our bifidobacteria. And I think that's a really, really important part of understanding if we're going to impact our children's microbiomes, where can we start? Well, as babies, let's start getting them optimal bifidobacteria.
Awesome. And then so coming back to the antibiotic use and the GALT, so the gut-associated lymphoid tissue, when we are exposed, let's say, to a course of antibiotics for whatever reason, and we're going to talk about what some of the justifications are for taking antibiotics. It's not just all bad, right? Like there is
Yep.
a use for them. What I'm hearing you say is that now these tight junctions that should sort of filter out particles and debris and pieces of food and whatever can now cross the gut, which is technically one of the things that I found very interesting is that the gut is technically still the outside of the body.
Yes. Yes.
Like,
We're a long hollow tube, right?
yeah, we're a long hollow. So as it passes from inside the tube, inside the lumen, across the gut barrier into the plasma, into the blood, this is the sort of origin, let's say, of the asthma and the food allergies and the eczema that you're discussing. Because if there's, let's say, a food particle that crosses and your developing immune system doesn't recognize it, I think that and I am not an immunologist, so this is a very simplified, feel free to correct me or redirect me here, but the immune system is going to look at that as foreign and now start creating antibodies against that particle.
Yeah. And, we have things slip through that shouldn't, and yet our immune system should be designed to not overreact. It should tolerate certain exposures. And it's really this loss of tolerance to whatever we're being exposed to, even some of the foods that we really shouldn't be reacting to. We start losing our ability to tolerate these inflammatory hits. And so at some point, our kids and even our immune systems will tip over. But it's happening at younger and younger ages, which is what we need to be really concerned about. I mean, when I was in training, and, I've been at this for a while. And so when I was in med school, this was in the mid-1990s, I mean, it was so rare to have a child who had any anaphylactic food allergies. I mean, unheard of, right?
Yeah.
And even in residency at UCSF, I finished in 2000. So that's, 24 years, right? In that time, it is this explosion of children with anaphylactic food allergies and the number of allergy centers that are popping up to try to assist with desensitization and the EpiPen shortages. And when I go on field trips, now my kids are older, I miss those field trip days, but I was often asked to chaperone. And I have to think it was also because I'm a pediatrician and I would carry these bags of medicine like EpiPens and asthma inhalers and you name it. Which, thinking back 20 years ago, if I had kids 20 years ago, that wouldn't be the case. And it's a relatively short span of time. 20 years might seem like a really long time. It's a little minuscule bit of time where our immune systems and our kids' immune systems have drastically changed.
Yeah, if you put a peanut butter sandwich in a child's lunch, like you might as well be sending a bomb to school.
Yeah.
There are kids that can't even be in the same room as peanut butter and jelly sandwich, let's say.
Yeah.
And to your point, I remember there was one girl in my elementary school that she had like everyone knew she was like the only one in the school. Like she had the really bad peanut allergy. And now it's like, let's say out of 20 kids, like 10 of them have some kind of allergy.
Something. These are true allergies, not even, the sensitivities that you and I help families or, patients with in terms of leaky gut and food sensitivities. But yeah, my daughter who's 14 now, she's like, when we're trying to have, they don't call them play dates anymore, but when they get together, right? And I'm thinking about what food.
I've had to correct my language too, because I have a 13-year-old. He's almost 14. And I'm like, you should get together. And he just looked at me. He's like, you are so uncool. It's not a play date. I know.
That's right.
I know. Yes. Sorry.
I still think of it as play date. Yeah. But, thinking about food, it's like, okay, so-and-so has a milk allergy. So-and-so has an egg allergy. So-and-so has, peanuts or cashews. And so really thinking carefully about what we're offering, even the quote healthy foods. You're like, okay, you got to be allergen free. And here's the thing. Our kids' immune systems have changed drastically. Their mental health has changed drastically. Our genes evolutionarily haven't changed. So that tells us we have to look at, we can no longer blame it on our genes. We can look at all of the external factors that are making our kids and our genes not work for us. And when we recognize that, it actually empowers us, right? It gives a little bit of the power back to us, because if we can understand what factors are making our genes not work for us, then we can also understand the factors that we have in our control
Right.
to shift it and then make our genes work for us again, which is what I love. I mean, we can't just be all doom and gloom and okay, the world is toxic, we can't live here. It's like, well, okay, how do we live here and thrive in spite of our toxic world? Because unfortunately, those toxins are here to stay no matter how much we try to minimize them.
Yeah, and we can talk about some of the sort of sneaky areas that we might be getting in our environment, certain like personal care products and what we cook with and how we clean our home and all of that kind of thing. But before we get on there, I do want to talk a little bit about the justification for antibiotics because I think that, and you are, one of the things I respect most about you is your very balanced view and sort of taking in holistic practices, vitalistic practices in your practice. And we'll talk about some of those today, as well as sort of the traditional model, that allopathic model that includes medicines like antibiotics. So let's talk to our moms about, and maybe you can even bracket it in terms of age if it would be
Yeah.
helpful. But what are some conditions where antibiotics are justified? So you mentioned with your children, 5 weeks of age, they had, course of antibiotics. Maybe it was appropriate, or maybe in hindsight, you were like, meh, maybe we could have waited it out. But what are some of the areas where it's like, yeah, we actually do need to do a course of drugs here?
Yeah, yeah. So, and this is such an important issue, not just from an individual, child and friendly standpoint, but also from a public health standpoint. And I actually literally devoted an entire chapter to the antibiotic issue and called it what every parent and practitioner should know about antibiotics. In some studies, we have seen that up to 70% of antibiotics written for children are inappropriately prescribed. So either they're prescribed for viral conditions like the common
Yes.
cold, for which antibiotics do zero, or perhaps they're just a bigger gun, like a way stronger antibiotic than what's needed for what's going on with your child. And so we can see from an individual standpoint why that's so significant, because antibiotics are the single most significant and immediate acute disruptor of the gut microbiome. I mean, there's nothing that's going to kind of wipe out a lot of the good stuff and kind of like raise the ground of your child's microbiome than antibiotics. Now, we do know that antibiotics are necessary sometimes, but even worldwide, we have this crisis of antibiotic resistance that is looming. And some experts are predicting that by 2050, which is right around the corner, antibiotic resistance is going to become a leading cause of death worldwide.
Wow.
And that's not okay. I mean, that's putting us back to, when Sir Fleming discovered penicillium, right? Way back. And we're going to be back to the point where potentially a very minor, quote, minor skin infection or maybe ear infection could become something deadly because we have no antibiotics to treat it. So we have to be good antibiotic stewards as patients and as practitioners. And anyone listening to you is not the person who goes into the doctor or the ER specifically for an antibiotic prescription.
Just in case.
Just in case, right?
Yeah.
I mean, there are parents like that, and it takes time to educate and say, look, let's prescribe when absolutely necessary. And it's not such a clear line. Now, I list in the book 6 questions to ask your doctor before you take an antibiotic prescription. The number one question, which is really important, is to simply ask, hey, doc, is this antibiotic really necessary? Now, they may say yes anyway because they may not know otherwise, right? But sometimes in a busy urgent care practice and you're seeing one patient, every 5-10 minutes, the easiest thing to do is to write the script. I'm not saying that's right or wrong. But also in some studies, it's been found that doctors who think that you want that antibiotic prescription are twice as likely to write that prescription, even if they don't think it's appropriate, right? And so just by asking that question in a partnership way, not in an adversarial way, but just like, hey, I'll do this if it's necessary for my child, but is it really necessary? Then lets that doctor know, oh, you didn't come here just to get the prescription and walk out the door. You're a little bit more conscientious, mindful, whatever it is about using antibiotics judiciously. So that really is the number one. Now, when would I consider an antibiotic really necessary? I do think looking at age groups is important. So, babies under 3 months of age, even under 6 months of age, I have a very low threshold to start antibiotics if they look really sick or if I'm concerned that there might be something infectious going on. If there's an obvious, older brother brought home a cold and now they have a fever and a cold, all right, I'm going to wait and watch. Now, under a month of age, nearly, pretty much worldwide, that your baby would get antibiotics and a full workup because under 1 month of age, their immune system is so underdeveloped that infections can become serious and spread very quickly.
I'm sorry to interrupt you. Is that true also if the baby's being breastfed? Does the baby have some sort of protection? Is there IgA or anything in the breast milk that's helping or no?
Yeah, in terms of bacterial infections, probably not. Now, in terms of, getting a viral infection and sailing through it, yes. I mean, they're gonna
Okay.
typically do better than a baby who does not have access to breast milk. And I see this, in families where, again, usually it's the older sibling, toddler, or whomever, like those germy little kids, right, come home and they bring
Little
home
petri
whatever,
dishes.
right?
Yeah.
Whether it's a stomach flu or cold or whatever it is. And, as a mom who's nursing and you're exhausted, a lot of times you get pretty sick too, right? Your
Yeah.
adrenals
Yeah.
are worn out and you're just, you're not sleeping. Hopefully you're taking care of yourself, but even that can be challenging. And so you might get really sick, but then the baby gets nothing or like hardly anything, right?
Okay.
Because
So
of
your
all
immune reaction won't necessarily transfer across the breast milk to protect the baby if you get
no,
sick.
no, it will. It will. So when you get sick, which is often I kind of joke with parents and moms, I'm like, well, it's actually kind of good that you're sick because now
Yeah.
you're making antibodies and
Yeah.
you're
Yeah.
protecting your newborn or you're protecting your baby at any
Okay.
age, right?
I
Um,
interrupted you. You were about to say 1 to 2 year olds with antibiotic use.
Oh, so under 6 months of age, I think, yeah, I probably would go ahead and even if you have to start while you're waiting for, blood cultures or whatever cultures, when they're over 6 months of age, there's a little more wiggle room and you really need to look at how the baby is responding and what they've been exposed to. Now, there are certain infections where I do treat with antibiotics. I treat strep throat with antibiotics because nowadays with strep bacteria, we're seeing more commonly an autoimmune reaction in kids called PANDAS or pediatric autoimmune neuropsychiatric disorders associated with strep, where kids, when they have a strep infection, which could be a strep throat or could be a skin strep infection like impetigo, and they develop either a sudden or even a subacute onset of increasing anxiety, separation worries, OCD, eating restrictions, cognitive impairments. And so when we can treat that strep bacteria immediately, we can often prevent that PANDAS from occurring. So I do want to jump on strep infections with the caveat that if your child has a sore throat, and even if they have white spots all over their tonsils, there's no way you can know that that's strep for sure without a culture. So I always ask for a culture. You can do a quick test in the office that can, pretty immediate within about 5 minutes or 15 minutes. Some tests tell you yes or no. They're kind of like the home COVID test, right? But they're not 100%. So I always want to also send off a culture as well. I've had some kids go to the ER or urgent care and have a horrible looking throat and be told by the doctor, oh, I can tell it's strep, so here's the antibiotic. You cannot distinguish a strep throat from a viral pharyngitis or throat infection. And in fact, some of the worst looking throats I've seen have been from viruses. The monovirus can cause similar reactions. So I always ask for confirmation that it is strep throat before
And
taking those
culture is the
antibiotics.
gold standard. You can't smell a difference between, let's say, bacterial or viral
No.
throat
Yeah.
infection. No.
You
Okay.
can't. Even sinus infections, right? That's another thing. I mean, often sinus infections may respond to antibiotics, but often with sinus infections, there's a combination. There may be some virus still lingering. There's often yeast or even mold I've cultured out, right? From sinuses. Of course, yeast, mold don't respond to antibiotics. And then there may be some bacteria there. So that's where really using more of your natural medicine tools can get at, I mean, herbs have such a beautiful synergy in being able to be broadly antimicrobial and treating, killing viruses, bacteria, and yeast or mold at the same time, which is often why I go to that first when it comes to ear infections or sinus infections. Because again, you can't tell, even by history or the smell or the color of the discharge, whether it's bacterial. So strep infection, I would treat with antibiotics. A urinary tract infection in a younger kiddo, what's my cutoff? Just depends on how sick they look. But I would do a culture and start antibiotics. If they're older, like if they're a teenager or maybe they're a middle schooler, and you think and it's an E. coli UTI, then yeah, go ahead and use a D-mannose first, cranberry extract and get in all of that. But when they're younger, especially if kids have a harder time explaining and being in tune with their bodies to know that they're getting better or worse, then I would do the antibiotics. And whooping cough. Whooping cough is another case where I would do the antibiotics, not necessarily for the person with whooping cough, because once you get to that cough, cough, cough stage, antibiotics don't really do much. You just have to kind of go through it and use your homeopathy and all your other tools. But it helps you be less contagious. It actually makes you not contagious once you start the antibiotics. And so in that way, then we can prevent spreading it to other people who may be more at risk, like our infants or our elderly.
Or our grandmothers who are watching the, yeah, exactly.
Yeah.
Okay.